Um, Hello everyone. I'm so sorry for that. I'm so sorry. I had to attend to something. So sorry for keeping you all waiting. Okay. Can we see my screen now? Hello?
Yes, yes.
Okay. So what I was saying for this immunosenescence. So I said that you said it already that the memory cells are preserved. The naive ones are the ones that are reduced. The naive B cells and the T cells are reduced. The memory cells are preserved. And we said immunosenescence is when the immune cells do not respond to new antigens. So when they get exposed to new antigens, either from an infection or exposure to vaccines, they don't respond. Why? It's because the only cells that are there are actually the memory cells. The naive T cells are reduced. Memory cells are cells that have memory of a previously encountered antigen. It means that they cannot respond to new antigens. They can only respond to a previously encountered antigen. That's why we call them memory cells. So it means that it is only if this individual get exposed to those previously encountered antigen that the memory cells can work. To respond to a new antigen, you need the activity of the naive T cells. Those are the ones that will respond to that new antigen, and they will also produce memory T cells or B cells against it so that they can store it for later. So, immunosenescence is now a condition in which you have reduced immune response to new antigens. So, if somebody has a new infection now, the person cannot respond to it. That is immunosenescence because of aging. Immunosenescence. If you vaccinate somebody and the person cannot mount immune response to that vaccine, it is not due to impaired memory cells, not due, but it is due to reduced naive T cells to differentiate into specific antibodies that can respond to the antigen and also produce memory cells to respond to it later. Is that statement clear to us? That explanation clear to us? Hello,
Yes.
Dr. Toby, do you get it now? You said I should repeat it again.
Yeah, so there's reduced production of the naive T cells. So I get it. Thanks.
So, musculoskeletal, we are looking at two major things. Yeah, reduction in skeletal muscle mass and reduction in bone mass. Reduction in skeletal muscle mass and reduction in the bone mass. So, what is causing reduction in skeletal muscle mass? Of course, number one, these people, there is a they are not even very with aging, they tend to be immobile. So there's high tendency of apoptotic damage to those muscle protein, causing the sarcopenia, reduction in the muscle mass. And again, even the epigenetic changes, DNA methylation, silence those DNA. They cannot produce the protein that is responsible for building those muscles. So that is why we have. Huh? Hello, 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 hello. Is someone saying something? Hello, can you guys hear me? Ah, network. Okay, thank you. Yeah, so I said, I think I stopped at this skeletal muscle mass that is reduced. So I said the reason is that most of them are inactive at with aging. So there is reduced functional stimulation of the muscles. So most of the muscles are taken down by apoptosis, sarcopenia. And at the same time, there's epigenetic modification, DNA methylation, there's silencing of protein synthesis, and you don't have those muscle proteins to form, and there's going to be a reduction in the muscle mass at the end because proteins are essential component of muscles. So um Reduction in bone mass. So the reason why there is a drop in the bone mass majorly lies with respect to the hormonal drop. So there's a drop in the hormonal level, both testosterone and estrogen. Both of them are essential in stimulating the osteoblast to deposit new bones. So because of drop in testosterone with advanced age, because of drop in estrogen with advanced age, that's why there's reduction in the bone mass, because you need hormonal support to stimulate osteoblasts to form new bones. So if the hormonal support is not there, the osteoblasts are not stimulated. You have resorption of those bones by apoptosis. I hope we remember that hormonal stimulation is also one of those things that can cause apoptosis. When there's withdrawal of hormonal stimulation, there's apoptosis. And
Yeah.
yeah, so and atrophy too. Yes, so that's what I want to say. So osteopenia, that's that because of the hormonal support that is reduced. Then of course the wear and tear, you know, wear and tear injury to the cartilage can cause thinning of the cartilage. Thinning of the cartilage. But most importantly, we should remember the skeletal muscle mass that is reduced and the bone mass that is reduced too. Nervous system. So the nervous system, the first thing that happens is reduction in the neurons. There's loss of the neurons. Number one, from the telomere shortening. We said it. The telomere shortening, there's death of those cells. The neurons are one of them. Remember, the neurons are even stable cells, they're permanent cells. They don't even replicate to replace themselves. So once it's time for them to die, they die. Once the telomere gets shortened to a level, they are taken off by apoptosis. So with aging, there's reduction of the neurons. They reduce in due to this genetic problem, this telomere shortening, due to this DNA methylation. They are not able to form proteins which are component of the neurons. And again, the mitochondria, you cannot generate ATP because the neurons are highly energy demanding. They need energy, ATP, to work. They're always pumping sodium and potassium everywhere to generate action potential. If there is mitochondrial dysfunction, there's no ATP to drive those processes, there's no protein to form their component, they die off. So there's going to be a reduction in the brain volume, which will be as a result of neuronal loss. And again, the cardiovascular problem that is causing reduced cardiac output is going to cause reduction in the cerebral blood flow. But what is peculiar to aging is that the function is still preserved and they have mild cognitive decline. Once you are seeing massive cognitive decline, they are forgetting things anyhow and they need help every time with things. That's a severe form of cognitive impairment. That's not in keeping with aging. So you want to think of other problems that you have with nervous system, like maybe Alzheimer's, maybe Lewy body, maybe vascular dementia in that situation. So the neurologic impairment in people that are elderly, you know, particularly at the early period of the aging, it's still kind of mild and their functions are still preserved. You can still see elderly people going about. You can even see some of them still moving, doing things, reading paper and all those things. They can still remember childhood memories and all those things. So the cognitive
Becoming
impairment,
president.
yeah, becoming oh my god, look at the brilliant idea that Dr. Lushola has dropped. Becoming president and controlling nation. That is it. Functional, functional neurologic impairment. So, special senses, uh, presbyopia, impaired accommodation. So, there's something called presbyopia. Presbyopia is so there's let me start by saying there's impairment of the four special senses. So the taste, the smell, the vision, and the hearing. Both of them, all of them are impaired. All of them are impaired. So presbyopia is when we have reduced ability to accommodate with age. And accommodation majorly is concerned with ability for the eye to focus a near image. That is it. So the ability of the eye to adjust the lens to focus a near image. Maybe they want to thicken that lens. They want to make it more biconvex so that they can convert that image and focus it on the retina. That is accommodation. But in aging, there is some changes that happen to the lens. The lens becomes more stiff. Yes, it loses its elastic fibers and it's becoming stiff. So you cannot alter the shape of the lens in response to the position of the image or the position of the object rather. Yes, because we tend to alter the shape of the lens with respect to the image. If it's or the object rather, I'm saying image, the object. If it's far or or near. So usually if the image is near, you want to thicken the lens so that you can convert the image directly on the retina. But in with aging, there's thickening of that lens. You cannot there's loss of elasticity of that lens is thickened, and you cannot adjust the shape in response to a near image majorly. So that is presbyopia. So you notice that elderly people, they don't typically see things that are near. They don't see. That's why when they want to read newspaper, you see them using glasses. Or some of them will try to bring that image far away. They try to bring it. They put it far away so that they can see. That is presbyopia. It's different from long-sightedness. Some people might be confusing for long-sightedness. The thing is, people that are presbyopic too, they are long-sighted. But the difference is the pathophysiology. What is causing the problem in focusing near image for presbyopia is that there's problem with the lens. They cannot adjust the shape of the lens because of the stiffness of that lens. But for hypermetropia or long-sightedness, they cannot see near image because of the fact that there's an irregularity with the shape of the eyeball. The eyeball is too short. So the image is focusing at the back of the retina. That's the problem. Or the cornea is abnormal. One of the two. That's what is causing hypermetropia. But presbyopia is strictly problem of the lens, which is associated with aging. That is it. So that's why they have different corrective measures. You can just wear spectacles or those contact lens for presbyopia, but you need to get your converging lens for your long sightedness. So reduced hearing, that is presbyocusis. So everything has this press in it. Presbyopia, presbycusis. Presbycusis is difficulty in hearing or gradual hearing loss due to degeneration of the hair cells in the inner part of the hair. So there are the hair cells there. Those ones are the ones that will receive the impulses from the middle hair. So they will receive it, they will vibrate, generate the impulses that will now be transmitted through the auditive nerve to the brain. So once there's degeneration of those hair cells with aging, there's presbycusis. Then impairment of smell and taste also occurs. Smell and taste, usually because of reduced salivation, that's the taste, and degeneration of both the taste and the smell receptors. So the smell and the taste receptors degenerate, and there is reduced saliva production. So those are the things that we should just know that all the four they are reduced with aging. That is it. So skin. Number one thing I want us to remember about the skin is that there are two types of aging with respect to the skin: intrinsic and extrinsic. Intrinsic and extrinsic. So the first one is physiologic. That's the chronological aging. That is aging that happens as you grow over the years, which is a chronological one, depending on your age. But photoaging is not chronological. Photoaging, that means that photoaging can even occur in somebody that is like 10 years old. If the person is exposed to so much sun, that is photoaging. I'm just joking. It cannot occur in 10 years old, but it's just that one is just basically about degree of exposure to the sun. So someone that gets exposed to sun for a long time can experience extrinsic aging, which is photoaging. So we'll talk about the differences between the two, but let's talk about the common thing. Number one, there is loss of the dermal collagen and elastin fibers. Very important. Collagen and the elastin fibers within the the skin are they are responsible for maintaining the tensile strength of that skin, making it very turgid and taut and strong. But once they are absent, the skin wrinkles. And once they are being absent, there's senile purpura. Now, these guys are absent because we've said it. There's epigenetic what? There's epigenetic methylation. So you cannot experience protein synthesis. These guys are protein, they are not being produced. And number two, genetic modification, telomere shortening. These guys are produced from the fibroblast. With time, the fibroblasts that are proliferating and depositing all these things will die off when their time is due. So you have no fibroblasts to produce them, and there's even epigenetic silences of the protein or the gene that codes for this collagen and elastic protein. So you can always link everything to this genetic and epigenetic malformation or problems. So in addition to wrinkling, there's senile purpura. So senile purpura just means there is bleeding or something like rash, like a red rash in the skin with old age. What happens is that the collagen and the elastin fibers tends to produce, or they form a, a framework for the vessels in the skin. They tend to support those vessels. By the time they are reduced, there's less vascular support and you have rupturing and damage to those vessels. Those are what brings about the bleeding, and that's what we call the semi purpura. So you see reddish bleeding or lesions in the skin. Me, I've not seen it before. I've not seen it before. So that's what we call the semi purpura. Easy bleeding due to fragility of those vessels with aging. So both of them, the wrinkling and the semi purpura, are as a result of the reduction in the dermal collagen and the dermal elastin. In addition to reduction in collagen and elastin, there's reduction in the sweat glands too. Sweat glands also reduces. Now, because of course they are made up of cells, those cells are going to undergo senescence. They are going to die off when the time is due after they've exceeded their replicative limit. So there's going to be reduction in sweat glands, and there's going to be heat stroke. So heat stroke is when you have abnormal elevation of the body core temperature more than 40 degrees Celsius, especially when maybe they just do little exercise or they just go out in the sun. They just notice that they cannot cool off their body. When they cannot cool off their body because they cannot sweat. Imagine someone goes out in the sun. The way you can cool off your body is by sweating, evaporation. But they don't have sweat glands to do that for them. The heat that is absorbed from that sun is retained in the body. And there's heat stroke. In fact, the temperature is as far high as 40 degree plus. So they have this so many malformation. They have these so many presentation rather. They can have tachycardia, they can have confusion, they can be dizzy, they can some can even convulse. But one thing that you always see is that the body temperature will be higher than normal. It will be as high as 40 degrees Celsius each stroke. That is due to reduction in the sweat gland, because once you sweat, the conversion of sweat from liquid to gas requires utilization of heat energy. So they absorb that heat energy from the body so that they can convert that liquid that's in sweat to gas so that it can evaporate. So the process of evaporation utilize heat energy from the body. That is, and again with sweating, you have vasodilation of the vessels. When there's vasodilation of the vessels, more blood flow containing heat moves to the surface of the body, and they can diffuse out of the body into the atmosphere, reducing the incidence of heat stroke. But someone that cannot sweat, there's no way they can disseminate those heat into the environment. They are retained in the body and cause heat stroke. So in addition to loss of sweat gland, there's also reduction in the sebaceous glands. And sebaceous secretion are oily. They are there to make the skin supple, clean, smooth. But if there is drop in the sebaceous secretion, the skin appears dry, thick, and what's the word now? Thick, dry, and let me see, flaky. Yes. So they are rough. Yeah, it's not smooth at all. It's very rough. Just imagine there's no you put oil in a place, it's going to look very, very radiant and shiny and smooth. But because of the reduced sebaceous secretion, their skin looks dry and rough. So those are three things I want us to remember. Reduction in dermal collagen and this elastin is also responsible for atrophy of the dermal epidermal junction, because at that junction you have so many collagen, so many fibroblasts that is providing support for the epidermis. So when you have reduction of all these collagen and dermis, you have flattening of that junction. You have flattening of that junction. So that is that. So we've talked about the two forms of the aging, the intrinsic and the extrinsic. So intrinsic is the one that happens chronologically as you age with number. So as somebody age, there's going to be a reduction in the biosynthetic activity of the dermal fibroblast. We've talked about that. The dermal fibroblast can no longer produce the protein, which is the collagen and the elastin, which will cause the wrinkling and the senile purpura. But for extrinsic aging, it's not due to chronology. It's not due to how old are you. It is due to excessive exposure to sun, which contain UVA and UVB radiation. So the UVA component is what degrades the dermal collagen and the elastin. So they can generate some agent that attacks this dermal collagen and elastin, degrades them, makes them fragmented, and those degradation products will now accumulate in the dermis. So when they accumulate in the dermis, they make the dermis look very thickened and fissured. So you are going to see something that looks like line in the face, and the face is going to look thickened. So that is solar elastosis. That's the consequence of um, um, extrinsic aging. So let me show us what it looks like. Solar elastosis. Elastosis. Solar elastosis. Yes. Eh? Hello? 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 You are sounding very distant. Maybe your network. Ah, God. Hey. Hello, Dr. Moravia. Hello?
Your brain.
My network is really very bad. I'm so sorry. I'm really very sorry.
Can you?
Hello? Hello?
Yeah, Dr. Mawali.
Okay. Okay. You can hear me now, Dr. Moravia. Can you hear me now? Hello? Ah, hello? Hello, can you hear me now? Hello? Uh,
Keeps coming and going.
hello? Hello, what about now?
Yes, can you? It's better.
Okay. Can you guys see my screen? Can you see the solar elastosis? This skin typically appears hello, are you guys there? I want to be sure that the network is good before I continue. Can you guys hear me? Hello?
So I can hear you.
You, but we're not sure if it's stable now.
Okay. Oh God. I don't know what's wrong with my network today. So let's just continue. So this is the appearance of the solar elastosis. So we are going to see thickening of the skin like this, and it's going to be fissured. There's going to be some lines there. So this is solar elastosis. So it's due to the sun exposure, particularly the UVA component causing degradation of the collagen and the um, elastin component of the dermis of the skin. So those degradation products are going to accumulate in the dermis, and they are going to make the skin appear this way. It's going to look.
Chief Mawali.
Hello.
Yes. So now
We can't. It's break.
it's breaking up.
So it means that someone that has this. So let's continue. So
Yes.
did we get this solar elastosis? Did you get the explanation of the solar elastosis? Hello?
Yes. You were explaining, and then you were trying to show a picture, and that
Oh,
was where.
okay. So this is the picture. This is the picture. So this is the picture here. So you can see this woman now. So what happens in solar elastosis is that there is exposure to too much sunlight. The UVA component of that radiation, that those ultraviolet radiation, the UVA component, they are going to cause damage to the collagen and the elastin fibers within the dermis and the degradation product. So the damage they typically cause is that they cause thickening of those fibers and they fragment them. So when they become thickened and they get fragmented, they deposit within the dermis and they cause this appearance to the skin. So you notice that the skin will appear thickened also, and there will be fissuring of the skin. You can see. So there's going to be lines like this, and there's going to be, it will appear thickened. So they are going to put in the question that there is thickening. So we can then, with exposure due to chronic exposure to sunlight. So that is solar elastosis. That is solar elastosis. So for the renal, so that is different from the intrinsic aging or chronological aging, which is due to reduction in the synthetic activity of the dermal fibroblasts. So it's not as if the collagen or the elastin are being modified by UVA. No, it is due to the fact that the ability of the fibroblasts to synthesize new collagen and elastin reduces. So you don't have any collagen and elastin to deposit in this dermis to maintain the tautness, the turgidity, or the tensile strength of the skin again. So it wrinkles and they can have senile purpura. Yes. So for the renal manifestation, of course, we've said it. There's problem with the telomere. When the telomere is reduced, those cells are going to die. So the neuron are going to reduce. That's why they say it at the age of 50 or 60, there's going to be I can't remember the number now. Number of neurons that dies off every year. There's a number that dies off every year from the age of 50 or 60. So, and it is due to this impairment with this telomere. So there's telomere shortening. Those cells begin to die by apoptosis. And at the end of the day, when there's a reduction in the number of nephrons within the kidney, there's a reduction in the glomerular filtration rate. That is very easy, because it is it's the nephron within the kidney that is filtering the plasma. And when the nephrons that are filtering the plasma reduces, the rate at which they filter too will reduce. So glomerular filtration rate reduces. And because of the cardiovascular problem that we've said, blood flow to the kidney also reduces, because blood flow to the kidney is 25% of cardiac output. When there's a reduction in the cardiac output, there's a reduction in the blood flow to the kidney. So renal blood flow also drops. And because of the fact that the nephrons have reduced, some synthetic function of those nephrons are also going to drop, which includes production of hormones. We know, for some of us that have done kidney, that have done the renal, we said the peritubular cells of the kidneys, the cells of, sorry, the interstitial cells of the peritubular capillaries, they produce erythropoietin. The proximal convoluted tubules, those cells there, they can produce dopamine. So because of the fact that the nephrons are reduced, the synthetic function also drops. So there's less hormonal production like vitamin D, like dopamine, like erythropoietin. And also generally, not peculiar to the renal only, but looking at the urogenital system entirely, they have voiding dysfunction. They have voiding dysfunction. So how does this voiding dysfunction happen? For females, it is typically due to weakness of the pelvic floor. So because the pelvic floor kind of provides support for the pelvic viscera, including the bladder, the uterus, and the rectum. That is why you notice that people having prolapse, vaginal prolapse, urethral prolapse, bladder prolapse, and all those things, it is very common with people that are old, because as they hold, the pelvic floor becomes weak, and you have less support for the bladder, the uterus, the rectum, and all those things. And again, the pelvic floor tends to help to support those structures that I've mentioned, particularly the bladder. and it doesn't make the urethra hypermobile. So the urethra is fixed, is stable, and the tone of the pelvic floor can also help with sustaining the tone of the bladder so that they can remain continent. But somebody that has problem or weakness with the pelvic floor, there's going to be less supply to the bladder and it becomes incontinent. Very, very important stuff. And the weakness to the pelvic floor comes from what? Degeneration of the muscles. The muscles become weak. Of course, they are not producing protein again. So the protein content of the muscles become reduced. And of course, there's going to be muscular degeneration. So body dysfunction can come. So they will have this type of stress incontinence. So stress incontinence is what typically occurs in people that are advanced in age, particularly the female sex. Why for males, they typically have this overflow incontinence. Why? Because in them, they can have prostatic benign hypertrophy. There's enlargement of the prostate. There's enlargement of the prostate, and when the prostate enlarges, it obstructs the urethra. So there's difficulty in urine passing through the urethra into the exterior. So they accumulate in the bladder. So the bladder begins to distend. And when there's a distension of the bladder, it accumulates so much urine, and the urine will start dribbling small by small. They just start dribbling little by little and all those kind of things. So when you see leakage of urine with inability to empty the bladder, you know that is overflow incontinence. So that typically occurs in the male that are elderly, while the stress incontinence due to problem with supporting the bladder from weakness of the pelvic floor occurs in the female part. So I hope this might be very easy for people that have done zero now to understand. But do we get that explanation, or should I come again with it? Should I try to repeat myself for the voiding dysfunction? Do you understand?
Please do. Please do.
So for the voiding dysfunction, I said for females, let's just know that what supports the bladder is the pelvic floor. There's something we call the pelvic floor or the pelvic diaphragm. They are muscles. In females, there's weakness of the pelvic muscles. That's why they tell them to do Kegel exercise so that they can strengthen those muscles. With aging, there's reduction in the production of protein from all these things that we said. DNA methylation. You cannot express those genes to code for protein again. So protein content reduces. Muscles degenerate. When those muscles weaken, they cannot support the bladder. When the bladder cannot be supported, it becomes incontinent. That is that. So in males, it is not really about the pelvic floor. It is about them having prostatic benign hypertrophy. So in someone that has a prostatic benign hypertrophy, there's because the prostatic gland is surrounding the prostatic urethra. Urethra is a channel through which urine enters from the bladder. So if there's a prostatic benign hypertrophy, there's compression of the urethra and urine cannot flow from the urethra. So they accumulate in the bladder. So there's like over distension of the bladder. So when that bladder becomes over distended, it will get to a point that it should just contract a little to bring little urine out. So that is what we call leakage of urine. That's what happens to someone that has overflow. They have so much urine accumulated in the bladder because they cannot expel it. And it will get to a point that the urine will just start leaking when there's overfilling of the bladder. It will just be leaking gradually. It will not be moving like a rush. It will just be leaking incontinently. It will just be leaking because the bladder is already over distended. Do you understand that? So that's the urinary incontinence that is present in the males. Overflow incontinence because of overfilling of the bladder and subsequent leakage of the urine. Do you understand?
And yes.
Okay. So for the reproductive, the problem in the reproductive drive is just reduction in the hormonal level. That is it. Remember, hormones are protein. Yes. And of course, the organs that will be producing those hormones will get tired with aging. So there's going to be a reduction in the level of testosterone. There's a reduction in the level of estrogen. Of course, that's what happens with aging. And when there's reduction in testosterone production, testicular atrophy occurs because testosterone is what is responsible for maintaining the function of the testes. So it's like, although it's produced from the testes, it also helps to support the process that happens in the testes, like spermatogenesis. So if the hormonal support to the testes is not present, there's no way the testes will work. So, and if we said it in the early part of pathology that hormonal support is responsible for functioning of a particular organ. If we withdraw hormonal support, that organ is going to atrophy. So because of the hormonal support in form of testosterone, the testes cannot perform their normal function, which is what? Production of sperm. And there's going to be testicular atrophy. So prostatic enlargement can happen, yes, but this culminates over the years. Because over the years, there's increased release of androgens, particularly from the pubertal years and downwards. Androgens begin to increase, and it will get to certain like 50, 60 to start dropping. But between the point of young age to like puberty down to like the 40s, there's a surge in the testosterone. So that one can exert a trophic effect on the prostatic epithelium, causing BPH. So that's why they say BPH is one of the problems of old people, particularly people above 50, because of the accumulated stimulation of the prostatic epithelium by those androgens. Yes. So prostatic enlargement is typically one of those features that we see in men, and they can have slower erection or ejaculation because testosterone is involved in mediating erection as well as ejaculation. So erection is when you want to achieve engorgement of the penis, maintaining the turgidity, vasodilation so that the blood can the corporal vessels can get filled with blood. Ejaculation is now when we have release of spermatozoa. Both of them are mediated by testosterone. So if it's reduced, there's slower erection, there's slower ejaculation. And there's prolongation of the refractory period. This one is also a function of the testosterone content. So if there's lower testosterone, there's a longer refractory period. Refractory period is just talking about the period by which somebody ejaculates and achieve erection again. Because if somebody ejaculates, there's determinant, there's flaccidity in the penis. So the period by which the person ejaculates now and achieve erection again, that is refractory period. It should not be very long. But in elderly people, because of the low testosterone, there's a longer refractory period between ejaculation and the next erection. So there's also reduction in libido, but the drop in libido is not as pronounced in females like in the guys. So there's a drop in libido in both sex, but it is more in males than females. So for the females, there's vulvovaginal atrophy. All these things are due to reduction in estrogen support. So the vagina atrophies, it shortens, it becomes thin, becomes dry. All these things are symptoms of and signs of menopause. There's vaginal atrophy. They have less interest in sex because of the reduction in the libido. The shortening of the vagina, it becomes thinned, it becomes dry because there's no estrogen to stimulate those vaginal glands, those battling glands to make their secretion. And of course, the pH is going to increase because there's going to be disruption of the flora, the flora in the vagina, like the lactobacillus that helps to produce acid. So if the lactobacillus is taken out, there's no acid again in the stomach, so the pH increases. So what I just want us to always remember for this reproductive is testicular atrophy because of reduction in testosterone support. The prostatic enlargement is a cumulative effect over the years. Then the erection problem and the refractory period. Then in females, atrophy, thinning, shortening, dryness, all those things are due to estrogen that is reduced in them. So there's reduction in the production of estrogen because, of course, there's going to be a tracial of the follicles in the ovary. So the ovarian follicles have been exhausted. So there's nothing to produce estrogen again because the highest source of estrogen in females from the ovary. So if there's follicular exhaustion with age, there's no source of estrogen, and all these things start happening. So respiratory. So this respiratory might be a little bit difficult to explain now, but let's just try if we can get it. So what typically happens in respiratory is that number one, all the muscles in the chest, they kind of atrophy. Not that they atrophy, but they are not strengthened because the protein content is reduced. So there's weakness of the respiratory muscles. The respiratory strength, the muscle strength of the respiratory compartment reduces. They cannot actively contract like that of a young person. So that is one. Another thing is that there's an increase in the lung compliance with aging. There's an increase in lung compliance. I'll tell us why. Within the alveoli, there's something we call an elastin fiber. So elastin fibers they surround the alveoli walls. What those elastin fiber does is to achieve elastic recoil. That is, they try to bring the alveolar wall inside. They try to bring it towards each other so that it can force air out of the alveoli into the atmosphere. Just imagine that something is collapsing on itself due to elastic recoil. You know, when we stretch an elastic, it recoils on itself. Yes. So that it can collapse that alveoli and move air out into the atmosphere. But that function is actually due to the elastin that is surrounding the alveoli. If there's a loss of the elastin, you don't have that recoil again. It means that if you stretch the alveoli, they don't collapse on themselves. They'll keep expanding. And their compliance increase. Because compliance is when you are saying you are filling something with water and that stuff is compliant. That is now distending. As you are filling with water, it is distending. That is when we say something is compliant. So with aging, there's degeneration of those elastic fibers. They can no longer recoil. So it means that if air fills into the alveoli, it will stretch, and become compliant as air is moving into the alveoli. Do you understand this phenomenon? Or I should try to explain again? Hello? Hello?
Hello. We can hear you.
Do we understand? No, if you don't understand, it's okay. I will try to explain again. We have not done respiratory. That is why. I know the old guys will understand what I'm saying. But the new guys, is it clear or should I explain again? You're not even giving me respect.
Please go over it one more time.
So now this is where you picture the elastic recoil. Just picture that you expand something, an elastic, maybe a rubber. If you stretch it, it's going to recoil. It's going to come back to its original shape. That is the recoil. Now, that is important in the lungs too. So that during expiration, when you take in air during inspiration, the alveoli can distend. And when it's time for expiration, the elastic recoil can help them come back together so that they can move the air out into the lungs. Elastic recoil. So recoil is when it comes back to itself so that they can come together. Can we picture what I'm saying? Can we picture the recoil? Can we picture that?
Yes.
So now
Yes.
with aging, there is damage to the elastic fiber because those things they are protein. So the elastic fiber component of the alveoli reduces. So when we take in air, they can stretch. They can stretch. They are compliant. They'll be stretching. But they cannot recoil because they need those elastic fibers not to stretch, but to recoil. So if they take in air during inspiration, you just have retention of the air into the alveoli. The alveoli will just keep stretching. But when it's time for expiration and those alveoli to collapse on themselves to bring out the air, they cannot do that because there is no elastic fiber to recoil so that they can move those air out. So that's why we are saying the lung compliance increases. Lung compliance increases because if something cannot collapse on itself, it will rather stay distended, right? That is it. It will rather be expanding because the opposite of recoil is expansion. Do you understand that?
Yes.
So if it cannot recoil, that means that it can expand. So, and with each air that is moving into that alveoli, the alveoli expanding in response to it is called compliance. So it means that if I if I feel a balloon if I keep blowing air into a balloon and that balloon is stretching, it is compliant. Yes. What is against compliance is recoil, because recoil is something collapsing on itself. So it means that if I'm blowing air into a balloon and it is stretching, it means that it is compliant and there's less recoil. That is it. Because if there's a recoil, it will collapse on itself and it will not expand. It will move the hair out. So that is what happens with aging. There's damage to the elastic fiber that should help with the recoil. So the only thing they can do is just to stretch. They just keep stretching. They are compliant. Hair is moving in, they are stretching with it. When it's time to move that hair out by elastic recoil, they cannot do it. So they will just remain filled with hair like that. There's a decrease in the chest wall compliance. There's an increase in the lung compliance, but there's a decrease in the chest wall compliance. The chest wall compliance is talking about when we take in air, the ability of the chest wall to expand. That is it, because the chest wall cavity needs to expand so that the alveoli can expand also and accommodate that air. That is chest wall compliance. That is very important in inspiration. But because of those chest wall muscles, they cannot expand. So that requires the activity of the chest wall muscles, that chest wall expansion. So because of the fibrosis and the degeneration of those muscles, the chest wall cannot expand with inspiration. So there's increased stiffness of the wall, of the chest wall, and reduced compliance. Reduction in the muscle strength, we've said that. So this reduction in the muscle strength is what we explain all these spirometric changes. There's a reduction in the FEV1. What is FEV1? Forced expiratory volume in 1 second. It means that if you try to tell the person to blow air out forcefully within 1 second, the volume of air that the person will blow out will be very minimized. Why? Because of reduced muscular strength. There's reduced muscular strength of the respiratory muscles. Respiratory muscles are weakened. So if the person tries to blow air out, the person will not be able to blow enough air. So there's a reduction in the forced expiratory volume in 1 second, FEV1. There's also a reduction in the FVC, which is the forced vital capacity. Once we are doing respiratory, we understand all this term very well. Forced vital capacity is when somebody takes a deep maximal inhalation. The person takes a very deep breath. Then you now tell the person to now expire, bring air out. The volume of air that the person will bring out will be very minimized because of that minimal respiratory effort due to weakness of the respiratory muscles. So there's going to be a drop in the forced vital capacity too. Residual volume is the volume of air that remains in the lungs after a maximal expiratory effort. Now, I want you guys to now try to relate it. If there's a reduction in the forced vital capacity, that is, you have taken a deep breath, and you try to blow out maximally as much as you can, and you are blowing out little, what do we think will happen to the air that is remaining in the lung? Will it be much or it will be less? The one that remains in the lung, will it be much or it will be less? If somebody tries to blow out here maximally, but the person is an aged person, there's a reduction in the muscle strength. Will the person able to blow out enough air when the person is expirating?
No.
No. So what will happen to the volume of air that is remaining in the lungs?
It should be increased.
So that's what we call the residual volume. So residual volume increases. Residual volume increases. So because of the fact that there's a reduction in the forced expiratory volume in 1 second and there's a reduction in the forced vital capacity, residual volume increases, but the total lung capacity is unchanged. So that's what we need to take note. In case we see it in arrow, that what are the following spirometric changes in aging? Total lung capacity is unchanged. That's the capacity of the lung. It does not change. The only thing that can change total lung capacity is when maybe the person has a pulmonary fibrosis that has shrunken the lungs. That's it. But once the lung is intact, there's nothing with it. There's no structural problem. the total lung capacity is unchanged. So there's something we call the AA gradient. So what I'll just use to explain this AA gradient that is increased is just the VQ mismatch. So what is the VQ mismatch? VQ is V is standing for ventilation, Q is standing for blood flow. So there is a respiratory membrane that moves here from the alveoli into the pulmonary capillary. So I just want us to know that the way here that we take in gets to our blood is that it moves from the alveoli across the respiratory membrane into the pulmonary capillary, then it gets to the blood. So there's something called ventilation perfusion mismatch, because we are expecting to have a balance between the ventilation, that is the amount of air that gets to the alveoli, and perfusion, that is the amount of blood that flows into the pulmonary capillary so that they can take the gas that is in the alveoli into the blood. Then the CO2 that is in the blood can also move into the alveoli. So oxygen can move from the alveoli across the respiratory membrane into the blood. CO2 can move from the blood into the alveoli. So we expect a balance to be reached. That is, the rate of ventilation should equal perfusion. They should be like very close to 1. But in aging, we remember that there's a problem with the cardiovascular system, reduced perfusion. So if there's a reduced perfusion, it means that the VQ ratio will be high, because if blood flow reduces respect to ventilation, you can see that the VQ, this ratio will increase. That's just mathematics. I hope we are able to follow what I'm saying. Just imagine that blood flow reduces. What will happen to this ratio?
Yes.
I hope that one is clear. I think that one is clear, Abby. So, hello?
Yes.
Okay.
Yes.
We can hear you.
So the VQ mismatch is in the increased pattern because there's a drop in the blood flow. That is it. If it is the ventilation that is reducing, what will be the pattern of the mismatch? Will it be increased or decreased?
Decrease.
It will be decreased. But in this situation, it is the blood flow that is reducing. So you are going to have an increased VQ ratio. That's what happens. Now, if there's an increased VQ ratio, it means that you have more air and little blood in the alveoli. You have more air in the alveoli and little blood in the pulmonary capillary to take the air in the alveoli to the blood. Yes, that's what it means. So that is what is going to cause the AA gradient. AA, this big A is talking about the partial pressure of oxygen in the alveoli. Small a is talking about partial pressure of oxygen in the blood. So now let's look at it. Someone that has a VQ mismatch, it means that ventilation is higher than blood flow. Do we think the partial pressure of oxygen in the alveoli is going to be affected? Please, I just want us to just think about it. You guys should just picture it. Is the partial pressure of oxygen in the alveoli going to be affected? Ventilation is not impaired. Will the partial pressure of oxygen in the alveoli going to be affected?
No.
No, it's not going to be affected. But there's problem with the blood flow. It means that oxygen in the alveoli cannot get into the blood. So what do you think will happen to the partial pressure of oxygen in the blood? Will it be normal? Will it increase or will it decrease? Which one? My people, there's no catch. Please let us respond. It's already late. Hello?
Increase.
No. See, look at what I'm saying. There is little blood flow in the pulmonary capillary. Air is in the alveoli. Now that air, that oxygen in the alveoli wants to get into the pulmonary capillaries. We are now saying that the blood flow is reduced. Do you think the air will be able to enter into that blood?
Okay.
Hmm?
No.
No.
So what will happen to the partial pressure of oxygen in the blood?
Be reduced.
It will
To
be
be
reduced.
reduced.
It will be reduced. What will happen to partial pressure of oxygen in the alveoli?
To be high.
Increase
No,
high.
it's not really high. It will be normal. It's just that they will not move. You cannot take.
Yeah, normal.
Unchanged.
Normal.
It will be unchanged. It will be normal. It will be unchanged. You cannot take in more hair than you need. It's a regulated process, so it cannot be increased. Now, let's now go back to the AA gradient. We've said it that the big A is talking about the partial pressure of oxygen in the alveoli. The small a is talking about partial pressure of oxygen in the blood. So if you look at the difference, what will happen? Is it going to be increased or decreased? The difference between them in someone that has a VQ mismatch
Increase.
is going to be increased. That is the simple explanation. It's going to be increased. So we must always remember, once you remember this VQ mismatch, you'll be able to figure out what is happening. VQ mismatch, ventilation to blood flow is kind of unequal. Blood flow is lesser than ventilation. It means that you cannot take in air from the lungs into the blood. Partial pressure of oxygen in the blood reduces, but partial pressure of oxygen in the alveoli is still normal. So if you find it different, it's going to be higher than normal because you have decreased the partial pressure of oxygen. Because this gradient is talking about a decrease. You are talking about a difference between partial. So if normally the normal partial pressure of oxygen in the alveoli should be 10 and that of the blood should be 5. So it means that AA gradient should be 5. 10 minus 5, 5. Now, if somebody has an increased VQ mismatch, blood flow to the lungs have reduced. The partial pressure of oxygen in the blood has reduced from 5 to like 3. But the partial pressure of oxygen in the alveoli is still normal, it's still 10. If you find the difference, it's now 10 minus 3. That's 7. That means you have increased the AA gradient as opposed to normal of 5. Do you understand it now?
Yes.
So, ventilatory response to hypoxial or hyperapnea is blunted. Yeah, so all those chemoreceptors cannot work, cannot respond again to all this. So they are very insensitive. With aging, there's insensitivity of the chemoreceptors to hypoxial and hypercapnia, and also cough is less vigorous. Of course, you need the muscles. You need to control the muscles to cough. Yeah. So that cough process cannot happen vigorously. And also there's impediment of the mucociliary clearance. So those cilia at the airway, they are damaged. They are reduced in number. So you cannot move out all those mucus that is accumulating in the airway. So that's why elderly people can be prone to having respiratory tract infection because of the impairment of the mucociliary clearance. The cilia that's located in the airway that helps us to move out cellular debris is reduced. And of course, the cough reflex too is kind of diminished. They cannot cough very actively, and blunting response of the chemoreceptors. So let's end with lipofuscin. So lipofuscin is more like amyloid too, similar thing. It's just that this one is a yellow-brown autofluorescent. That means if you shine light to it, it will repel. It will also um, reflect light. That's it. Autofluorescent. Shine light to it, it will reflect light. It doesn't absorb the light, it will reflect it again. So autofluorescent wear and tear pigment. So it's a pigment that's associated with aging. So as we grow, you have accumulation of that lipofuscin. It's actually a breakdown product of the membranes of organelles, particularly the mitochondrion and the endoplasmic reticulum. So all the membranes of the mitochondrion and the endoplasmic reticulum becomes degraded, and what is forming the membrane is lipids. So, and we know that with aging we have production of all these free radicals too. Of course, mitochondrial dysfunction is happening. There's free radicals dangling around from incomplete reduction of water. So those free radicals can easily react with those like lipids within those degraded membrane, and they can form lipofuscin. So lipofuscin is derived from lipid peroxidation of polyunsaturated lipids from degraded subcellular membrane. So they contain phospholipids, lipids complex with protein. That is it. But those lipids and phospholipids are actually peroxidized. peroxidized. So peroxidized lipid, phospholipid now complex with protein. That's what forms the lipofuscin. So one thing about this yellow-brown pigment is that they can deposit in almost all organs of the body: heart, colon, liver, eye, and other things. So some studies have shown that they don't really cause any damage, but some studies have shown that they can be implicated in explaining some injuries to some structures in the body, particularly the eye. They can be responsible for causing macular degeneration of the eye. So what I just want us to remember about lipofuscin is the color, number one, yellow brownish pigment that is a mixture of lipid and protein, lipoprotein. It's more like a lipoprotein. It's a mixture of lipid and lipoprotein. What is the source of this lipid? Degraded membranes of our organelles like mitochondria and endoplasmic reticulum. And when they become degraded, they are complex with free radicals to form lipoperoxide. So the lipoperoxidation of all those polyunsaturated lipids complex with protein form lipofuscin that can deposit in almost all the organs of the body. So people that are old, if you do the autopsy of their organs, you are going to see accumulation of this lipofuscin.